before we get into this episode with Professor Martin Sullivan on everything Lisfranc, to give you some context as to what his week looks like. He is a leading international foot and ankle surgeon who is called to treat and correct many foot and ankle conditions, from the unstable ankle to Lisfranc's to syndesmosis. He looks after a wide variety of populations, from elite athletes to the everyday person. He is currently the director of the North Shore Foot and Ankle Clinic in Sydney and a consultant surgeon at St Vincent's Clinic. He was previously a consultant to the University of Sydney Sports Clinic at the Cumberland Health and Research Centre, and he is on the editorial board of the International Journal of New Techniques in the Foot and Ankle Surgery. He has numerous published studies and has been publishing for over 20 years, and is also responsible for developing the endoscopic surgical technique on insertional Achilles tendon disorders in 1996. In 1999, he was an invited guest of the American Orthopedic Foot and Ankle Society to speak on advances in arthroscope foot and ankle surgery. Martin pioneered the rapid rehabilitation program following ankle ligament reconstruction and has an extensive experience with Australian and international elite guests. He has been involved in the education of Australian sports physio, podiatrists, physicians, as well as nurses and medical students for many years. When we speak about the Lisfranc complex, we talk about lots of different topics, but the ones that are most relevant clinically: how to diagnose, what happens when that presents to the clinic, what's it going to present like, what are some of the potential signs you may see, what does the surgery involve, what does the post-operative rehab need, and everything else you need to know to be well across the literature on Lisfranc.
Yeah, no, I mean, it's a great topic. So it's obviously important to get all the current information out to everyone. I'm not sure how many listeners you have, but by way of background, when I came back from the US in 1994, if you're an athlete and you had a Lisfranc injury, essentially it was a career-ending injury, and that's if it was diagnosed. Right. So majority of them weren't diagnosed initially. Partly there was imaging, MRI wasn't around then, but just awareness. But funnily enough, I used to lecture to the physios at Cumberland when I first got back, and it's just a matter of, once you show people, like anything, train them, show them. I used to get referrals from physiotherapists of Lisfranc injuries diagnosed clinically. And this is way back in the 90s. So a lot's changed since then, particularly in terms of the management.
Yeah, it's interesting that, hey, it's like once you know that to look for something, you see 10 of them in that week.
That's right. You know, you may not have seen it, but it's seen you. But
for sure.
Yeah, it's a great topic. The ligament, as you know, it's a very strong ligament. It's got three parts to it. There's a dorsal component, a plantar component, and the interosseous. Basically the part of the ligament that connects the second metatarsal to the cuneiform, the medial cuneiform. The interosseous part is the strong part. It's the part that causes all the stability between the two. And for those it's hard at doing a podcast sort of without any diagrams or images, but essentially for all your listeners, if you think of the foot, if you think of your hand, that your thumb is the first rail or your big toe, and your fingers is the rest of your foot. And essentially that ligament connects your big toe to the rest of your foot. And if that ligament gets torn, then you've got a disconnection between the big toe and the rest of the foot. And if you think of it like that, then you can apply a lot of different ways of all the clinical ways it may present. And probably, again, if you look at books, they talk about different tests you can do, but if you just look at a patient's foot with a Lisfranc injury that's got a rupture, then their foot's going to be wider, because suddenly you've got a gap between your big toe and the rest of the foot, and so it has to widen. So apart from the swelling, obviously they're going to have a lot of swelling and pain initially, but you're going to have a foot that's wider than their other foot. So you just need to obviously take off both shoes. And, if they come to my office, you want to look at both feet, and it's pretty obvious. You point out to the patient, how wide that foot is. You can trace the outline of the foot on a piece of paper and measure it and compare it to the other one. But it's very simple. You just need to look with your eyes, and you can see that it's obviously a lot wider.
Does that happen
So,
relatively quickly after the injury, or does it take some time for that to develop?
yeah, usually you can get swelling fairly quickly. You know, basically in the past it was diagnosed as a sprain, like a foot sprain, which, as you know, is not a diagnosis. So they had swelling there and they had pain. It varies. I mean, everybody's different in terms of pain response, but generally you will get swelling there. And in your office, if you see them afterwards, particularly say the next day or a few days later, few of the things you can do, just get them to try and stand on their toes. That's a very good provocation test, because if the joint is unstable between the big toe and the rest of the foot, then they'll have trouble doing that. Not apart from causing pain, they'll just feel like it feels weak or it feels unstable. You don't want to put words into their mouth. So, so they're simple things you can do. If you read up on it, there's a thing called a piano key test, and essentially, if you think about it, what you're doing is you're getting the second metatarsal. You're stabilizing the big toe, the first metatarsal. You stabilize that, and you press down on the second metatarsal. And like a piano key, if the ligament's been disrupted, and it can involve also the dorsal components, so not necessarily a grade 3 or complete rupture, then there'll be more movement in a dorsal plantar plane. And then you check with the other foot. So usually I'll get both their feet on my knees in my office, and I'll just check one with the other. Then I'll get them to close their eyes, and I get them to tell me what they feel. And most patients, apart from assuming it's not too painful, they'll say that it moves more if that ligament is unstable.
Why do you think they typically get missed quite a lot? And to give you some more context for our listeners, and most people that listen are health professionals, and we've got, between the podcast and our social media, a couple of thousand people each week. And when we talked about doing this topic on the socials, it was a really well-received topic, because people know about them, know they're really important. But even the literature suggests that they do get missed quite a bit, similar to navicular stress fractures. They can go undiagnosed for some time. Is there a reason you think that is? Because people don't suspect it, or the tests aren't as great, or what do you think?
I think it's a combination. I think awareness. I think people are obviously more aware now because of high-profile athletes who have the injuries, gets into the media. Again, social media, what you guys are doing, podcast. Generally, the whole medical landscape has changed dramatically in the last 5 years in terms of getting information out there. I think the problem with the injury essentially, you got to think of it, this ligament, it binds, it's just essentially binding the big toe to the rest of the foot. And when it's divided, you get a small gap there. So it may be enough, there may be enough room when I operate and explore the ligament, I can get a freer dissector, which is probably about 1 millimeter wide between the two, but there's no resistance. It just flops in between the two. You're not going to see a major change on an X-ray unless you get the high energy Lisfrancs that you get in the motor vehicle accidents. So the X-ray changes may be very subtle. People talk about weight-bearing X-rays, and you may see, again, widening and comparing it to the other side. For me, you can get as much information just by looking at their feet and listening to the stories. A lot of the elite athletes that come to see me will usually have the injury on their phone. So and that includes, syndesmosis injury. I'll be able to see the injury on their phone, and that helps a lot. But I think for people to diagnose, you've got to think about it first, then look at the patients. Obviously, you want to look at both feet. Again, do simple clinical tests, get them to walk on their toes, do the piano key test. Don't be misled. If the X-rays are more than likely, it's going to be very subtle, and the report's usually going to be wrong. So a lot of the elite athletes that I'd operate on, though, will come with an MRI without an X-ray. Okay, so that's just the way it is, and the sports doctors will have them MRI'd within 24 hours of the injury, and they'll have it diagnosed. So it's very important, though, for the listeners to work out that you're dealing with a spectrum. You're dealing with an injury that may be just one ligament, which is the Lisfranc ligament, can be partially or completely torn, or You've got the high energy injuries where you've got dislocation of the tarsometatarsal joints. You've got chondral damage within those joints. And if you take an X-ray, it's obvious that they're going to have a problem. But having said that, probably a lot of your listeners won't realise that someone who has a high energy injury in a motor vehicle accident ends up in intensive care, may end up in orthopedic ward for 2 months, 6 weeks, 8 weeks at a time. The thing that stops their rehab 12 months after their high energy injuries in motor vehicle accidents is usually the foot, because they've been in a coma in intensive care. They've got this high energy Lisfranc injury, and that's the last thing any of the doctors are usually going to look at. So, and that's not treated properly. And that's that's the thing that prevents their rehab. But for what I'm doing now, obviously with the elite athletes, it's a total different ball game when you're dealing with an isolated ligamentous injury.
And we've seen some research recently come out in the last 5 years around, ACL surgery versus first non-surgical management. Is there ever a case at all, depending on the grade with a Lisfranc, for someone not to have surgery versus have surgery? I mean, all the cases that we have seen have all had surgery, but I don't think I can recall one that I've seen where they haven't. Have you ever suggested someone go through some normal rehab and see how they go? Does it depend on the grade? What factors play into that?
Yeah, absolutely. Because if someone had an MRI and they said the interosseous was intact, so say the dorsal ligament and some of the capsular structures in that area were torn and they might have bone bruising or might have some fractures of the bases of the cuneiforms on the MRI, then I would definitely, and I felt clinically they weren't that unstable, then I would treat them non-operatively. In terms of research, the paper that I published in the American Journal of Sports Medicine in the elite athletes that had isolated Lisfranc injuries that were unstable. Now, 2 of those patients, one was actually an Origin player from up your way. He had played 5 months with a complete tear of his Lisfranc, but he didn't have any pain.
Wow.
So what they did during the season was tape him, bind him up. But his main symptom was instability. And because he didn't have pain, well, they felt that they didn't really have to do anything. And I agreed with them. And then during the off season, I stabilized him with the interosseous device. And he then played Origin, 4 months later after that. So in the other series in that group, there was a ballerina that was treated, again, initially non-operatively, not by me. And then she came to see me probably 6 months after her injury, and she was unstable. So pain wasn't the main problem. It was more that every time they go up on, and particularly being a ballerina, go up on point, she felt like foot was going to give way. But yeah, there is a case there. You're dealing with a spectrum of injuries, and there is a role for conservative treatment. In terms of conservative treatment, I would initially, you want to get the swelling down, probably put them in a cam walker boot. As far as loading it and weight bearing, you would decide at what point you're going to let them weight bear, and then you'd monitor them. And then if they got through that period, then you're obviously going to look for a cushioning orthotic basically in the shoe. And a lot of the shoes around at the moment are amazing in terms of cushioning and support. I mean, there's been a huge change in shoe wear in the last 5 years in terms of what you can achieve in terms of stability, rigid soles, and cushioning.
Was that dependent on their grades, the ones that were treated more non-operatively or conservatively initially? Was that dependent on their grade or their symptoms, or a combination of both, like
obviously. I'm not going to usually see I may see an acute injury where I decide not to operate, but a lot of the ones that we published, there were 7 patients, they're all elite, most of them NRL people, but 2 of the patients that had conservative treatment, I'm not sure on what basis they decided to treat them conservatively initially. Again, from my point of view, the MRI, if the interosseous is torn and they're unstable, then I'm going to stabilize them.
I want to give you a clinical scenario. If somebody comes into the clinic on their initial appointment, they play sport on the weekend, and you've gone through your battery test, and you are suspicious of a Lisfranc, and let's say a more severe one where that interosseous ligament is damaged or ruptured, what would be your kind of on-the-spot advice for physios and podiatrists and chiros and doctors? Is it a matter of going into a boot or going complete non-weight bearing, getting bilateral weight bearing x-rays and an MRI, or straight to the sports doctor who will then, liaise with the specialist?
Oh, I think if you're thinking they've had a Lisfranc injury and your initial management is obviously get the swelling down, you want to make them comfortable. If you got access to game readers or anything that's going to get the swelling down as quickly as possible, that's a good thing. Make them comfortable, and then you've got to go through the process of re-examining and deciding if you're going to get weight-bearing x-rays is always a useful thing. I think in the first instance, again, in the elite world, the first go-to investigation is usually an MRI. MRI is a better test. There's no doubt MRI is a way better test than a weight-bearing x-ray in these patients who have these isolated Lisfranc ligament injuries. But if they can, the first thing is get them to think about it. Once they've thought about it, start the initial, RICE treatment, get them in a cam walker boot, provide support. Tell them not to have the boot on too tight, particularly with the straps. It's not uncommon to get problems with compression of the nerves. The nerves are already stretched on the dorsum of the foot with the bleeding, with the swelling. So talk to them about that, and then go through your process of, in your situation, I would say that probably x-rays first, and then if you're still not happy, you still think that's what they've done, you need to should pretty much get an MRI asking the question, have they torn their Lisfranc ligament?
And if there are long-term complications, if it is misdiagnosed, I mean, of course, running into rehab problems, and they probably won't improve very much to a certain point, but are there any long-term problems if they aren't, managed surgically and they are quite severe?
Yeah, so, I mean, if the ligament doesn't heal and that hasn't been diagnosed, the ligament doesn't heal, there's issues with instability in that area. You lead to biomechanical changes across the TMT joints in the midfoot, and that can then lead to arthritis, similar to undiagnosed syndesmosis in the ankle. They're very similar in that you can end up with altered mechanics, and then you get joint changes and arthritis in the midfoot. I think it's important, though, the high energy injuries. What's amazing, when you operate on the high energy, motor vehicle accident type Lisfrancs, when you get in there, the joints, there's articular cartilage damage within the TNT joints, and that's why a lot of them will, no matter how well you can reconstruct their midfoot, they'll go on to develop arthritis anyway.
Are you seeing a lot of these people later on in life, like 5, 10, 15 years with arthritis, if they are high energy ones?
Yeah, any intra-articular joint that's damaged, you can, no matter how well the surgery goes, you can end up with arthritis. It's variable in terms of the onset. It's a bit like, having a calcaneal fracture intra-articular, where you can develop arthritis within 6 months or even, 20 years later. Same with snowboarders fracture. You can see patients develop arthritis. I've seen that. Similar injuries, hard to diagnose on x-ray sometimes, and it's amazing even with that injury, when you look inside the joint, you can see where all the joint's been compressed and the articular cartilage has been damaged. I think people, obviously, with the work that I do with the chondrocyte transplants and stuff in the ankle with talar domes, they don't appreciate, especially trauma surgeons don't appreciate articular cartilage probably as much as they should.
Yeah, that's super interesting. With the surgeries, there's been a little bit of a shift, or maybe a development towards using more of like a tightrope situation opposed to the plate, which was later then having to be removed. What's the decision making in deciding whether you go down one route or the other, or is the plate no longer necessary? Can you just do the tightrope, or does it again depend on the severity of the injury?
Yeah. Well, certainly, so let's stick with, because you're sports medicine, so stick with the elite athletes. So they're usually an isolated ligament injury. So for those injuries, say in the past, they would, similar to the syndesmosis, use a screw, and the screw would go across from the medial cuneiform to the second metatarsal. If you had the screw, then you wouldn't be able to put weight on it generally for 3 months. And then you had to take, and then you had to take the screw out. Then you took the screw out, so that's another surgery, and then you started the rehab. So that essentially was a 6 months out of action. So the intraosseous suture devices, not allowed to use tightrope because it's commercial product. It's a bit like sort of Heinz sauce or PMU sauce, but so that sort of device, right? It looks like a Nutrigrain and a button, and it's got 4 strands of material that between the 2 bits of metal. So when I started using the tightrope device, just like within the syndesmosis injuries, what it means is I can fully weight bear them within 4 weeks. And we published this in this American journal on all the elite athletes. And then they're starting physio. I get them in the pool. If the wounds are okay, they're in the pool at deep water running at 3 weeks. They're full weight bearing in the Cam Walker boot at 4. And we want them pretty much getting going. And the physios will send me WhatsApp videos of them training. And then week by week, I'll be involved in trying to push their recovery. And we published that we now get them back playing, elite athletes, that is, in anywhere from 12 to 16 weeks. Whereas if you look at the work from Calder in the UK with the soccer players, his work, they were similar group of patients, again, comparing apples to apples, was sort of 26 weeks using screw device. So essentially you can halve the return to play in that group of patients. Now, when you get into the high energy injuries, then you're starting to use plates, and you can use plates that basically bridge the joints, and then you go and remove them. You use everything that's available in those injuries because you're dealing with a very unstable situation involving the transverse arch of the foot. So in that situation, still you may use plates and then go and take them out, or you may not take them out, depending on the situation. But the big thing is the screw, like in the syndesmosis, putting a screw across with the ankle, where you couldn't put weight on it for 2 months, and then you took the screw out, and then it was a 4-month thing. Now I can get people back in 5-6 weeks NRL, using the tightrope or interosseous device. So.
And for orthopedics, does that come down to just the availability of what they know, or their history of what surgeries that they've done, or just confidence to win the surgery? Because it sounds like it would be pretty clear to not use the screw and use the other option, but what is usually guiding?
Oh, yeah, I think it takes, obviously because of the work, firstly, you've got to publish your data, which you've done. It's important always to go back to research. And if people want to look up, there's a hell of a lot of work done now on looking at all the work published with using these devices on Lisfranc and how you can get back a lot quicker compared to the screw. As far as, you wouldn't be advocating for people to do techniques that they're not familiar with, I think. And like anything, things takes a while to get across to the mainstream. It's a process. So I think in terms of technique changes, particularly for the athletes, the public health system in Australia doesn't really deal with it can't really deal with acute injuries in elite athletes. So they're dealt in the private sector, but you're basically using, the technology's changed. I mean, it's changed a hell of a lot in the last 25 years. And with those changes have led to improvements in outcomes. So, but that will filter across mainstream.
When you're doing the surgery and you're obviously, within that area, are you commonly seeing the imaging relate to what you're seeing inside the foot and the ankle? Like, is there a pretty good matchup, or you're going in there and it's usually a lot worse or it's a lot better?
Yeah, MRI, I think MRI is generally the best if you're talking about investigations and stuff, but it's not uncommon. For example, even with the cynos, I can have a patient where I'll do the arthroscope, confirm that everything's unstable, put the tightrope across, but they're going to have we know that 86% of patients with cynos injuries have chondral damage, and the MRI may not pick that up. And that's the important thing with MRI is you've got to know about its limitations. It's the best available, non-invasive, but looking in with your own eyes is a hell of a lot better than that. So again, working also with musculoskeletal radiologists, obviously they're going to have a better handle on things than just a general trained radiologist. Again, it all depends on expertise, but so you've just got to be careful. I think for your listeners, if clinically they think, say, for example, there's a Lisfranc injury and they're not happy with the imaging or the reporting, then you've got to follow your own instincts.
Is there any considerations from a rehab perspective after I'm going to call it a tightrope injury because that's the first word that comes to mind. Right. But is there any particular considerations that you need to be aware of in the earlier stages? For example, like after an ACL reconstruction, you need to give that graft site that time to mature. Is there anything like that we need to be aware of, or is it once that non-weight bearing time period is up, you're free to sort of push as tolerated?
Yeah, I mean, that's a good point. So the thing about the devices that we've got available, a lot of people there's a misconception that you're relying on the device to provide the stability. What we're doing essentially, an internal brace or interosseous suture device, what it's doing is providing a milieu or an environment to get the best possible outcome for the ligament to heal, because the forces are acting in the opposite direction. So what you're doing is you're putting in the device, and then what you're wanting then is give a reliable or predictable course so that the ligaments heal, which we know would usually heal over a 2 to 4 week period. And based on the biology of the ligament healing, then we can be more aggressive with the rehab. So in Lisfranc, what we would do is after 4 weeks, they're fully weight bearing in the boot. They're already getting out of the boot and get their ankle moving with the physios, but then I would be getting them in the pool, and then also starting to work in with you in terms of, you might get them on Alter G, again, working on the swelling. They may tend to get a bit of joint reaction, so you use anti-inflammatories, but you would just generally progress them week by week, depending on how they respond. The stability issue is once that ligament's healed, then the device, just like with the screw, it's superfluous. It's the ligaments that are providing the stability, not the device.
Mm. And are there any risk factors? I've read a couple of papers, potentially, foot type, maybe if you have a more cavus foot or a shorter metatarsal. Are there any consistent risk factors you see that may increase your risk of either a Lisfranc injury or potentially infecting the rehab?
Yeah, I think cavus feet generally, there's a lot of stuff. Now, if you're an athlete, I'd much rather have a flat foot than a cavus foot.
Mm-hmm.
They're tight. They're going to have tight tendo Achilles. They're more prone to getting plantar fascial issues. They're more prone to instability, ankle, peroneal tendon tears. I mean, they're just and tight. So I think, you've got to work in. One of the things that, in terms of being, if you're involved with physiotherapy or rehab, one of the things I'm often telling the patients to go back and tell their physios is, if say they've had an injury and they have been inactive even for 2 weeks, then say it's their left side, then every muscle group on that left side from the waist down is going to be affected. So they've got to rehab. You can't just focus on the foot. You've got to focus on their thigh, their quads, their glutes, and work in with that, because it only takes, in an elite athlete, you're looking at about 4 days before they're starting to get muscle atrophy within 3 or 4 days. So, and the other thing is getting tight. I don't think, if you look at a lot of the hamstring injuries that are occurring now, NRL and stuff, you start to wonder how much time are they putting into stretching. I mean, if you look after dancers, most professional dance companies will stretch 20 minutes before they actually get on the floor every day. And you know how flexible they are. So I think, we could do a lot more in terms of focusing on stretching. But in the rehab, I think it's important to be a bit more holistic, look at the whole limb when you start that, and then work in with your surgeon or your sports doctor. I think working in is very important.
That's not good news. Kelly's got the highest arch foot on earth, and I'm a bit more flatter, so
and that probably had everything that you rattled off. I've had like plantar fasciitis, Achilles tendinopathy, recurrent ankle sprains. Doomed.
Yeah.
I'll be knocking on your door in a few years' time.
So you just got to do a whole lot more with stretching. But I mean, the shoe wear is important too for you, right?
Yeah. So do you, like the cases that you are seeing, are you recommending, as you said, usually stiffer rocket-soled shoes, especially to the forefoot, and we have so many options now. Are you recommending foot orthoses in through there as well, relatively stiff devices? Are people coming out of them in the long term, or is it something that they always wear for the next 12 months or 18 months? What's your advice there?
Oh, you mean without injury?
Yeah, with all this strength and then supporting the midfoot and things.
Yeah, I think you would basically, I mean, you'd want lots of cushioning, and shoe wear is important for them. It's a serious injury, and even if they get a good outcome, it's probably something that you want to then ensure that they don't go on to develop any further changes. So that's long term. I think that's a good thing.
Yeah, and you mentioned just before, if you see some chondral damage, what are you doing for that when it's intra-articular? You say you have some different techniques or potential treatments for that if there's articular cartilage damage?
I know that's in the ankle, say for a talar dome, large talar dome. One of the things I've been doing for nearly 20 years and involved with in the International Congress research for particular cartilage damage is we have, chondrocyte transplanting for large defects that fail, microfracture or debridement, same thing. But that's a different issue. But in the midfoot, what the important thing is, what I was trying to say is you get someone with where the engine basically goes through the floor of the car, their foot gets stuck, and there's nowhere for the foot to go, and basically the TMT joints are completely disrupted. Well, when you actually operate on those patients and you look inside those joints, so even if you put the foot exactly the way it was before their injury back together, they're going to get arthritis because you look inside, there's bits of articular cartilage that are fractured off, and you're washing that out at the time of the injury. So you know that they're more than likely going to get arthritis. So in those people, there's for example, someone who comes off a building, or jumps off a building or whatever, and they fracture Lisfranc, a high energy injury, and particularly work-related injuries, there is a case to doing primary fusions in that group. Again, it's not your elite athlete type patient, but because of essentially they're going to develop arthritis, have ongoing problems with pain. So there is enough in the literature to support probably primary arthrodesis of the TMT joints in that group of patients. So.
Is there a downside to performing the fusion early? Like I imagine that would be quite restrictive from a functional standpoint in some scenarios if they were involved in some sort of running-based sports. So would you try to put that off as long as possible, or do you think that there is a place for doing that as the first line intervention?
Yeah, I think the role for the fusion is, these people that you're fusing, they've either got established arthritis. The role of primary fusion is someone with a high energy injury. You jump off a building and you basically want to get them back to work. And so instead of doing 3 or 4 surgeries, you can do the primary fusion and get them back. But generally, someone who's got arthritis in the midfoot, you definitely, fusion is the last option. You're looking at orthotics and shoe management first, gait training, anti-inflammatories, and most people that I would fuse their midfoots for arthritis, where say the joint's just worn out, they might be in their 50s or 60s. Those people are fairly, their quality of life's not great and their pain profile's high and they've failed everything else. They've tried everything else. For those of you that don't know, when you go through a midfoot fusion, then there's 6 weeks non-weight bearing and then 6 weeks weight bearing in a boot. So it's 3 months. They may require bone grafting as well. So it's not a minor thing. But, I'm sure that's a separate subset of patients that you're dealing with.
But you must have read my mind, because I was just about to ask you that question. One of the questions that come through, we put it out on our socials, so it's probably split between podiatry and physio, was the surgical option for midfoot osteoarthritis. I mean, similar to the knee, people just have a low level of a kind of an ache pain in orthotics and shoes. There's a little bit of research for cortisone, but that doesn't seem to work very well for very long. But the midfoot fusion, people wanted to know, what the outcomes were. Like, do people generally get back to a quality of life? Are they better or worse than what they were prior to the surgery? Like, what have you found in your work?
Yeah, so midfoot fusions for the people you operate on generally. So when you do fuse a joint, there's a 10% chance statistically that it won't fuse. And if you're a smoker, virtually it's going to be 100% they won't fuse. So, it's a good in terms of relieving pain. Most of the people, their gait's going to improve, not get worse, because the joints are already stiff. So what you're trying to do is relieve their pain, which improves their walking duration, everything. It's just that it's very difficult. Any patient who has to be 6 weeks non-weight bearing, they can't get their foot wet for the first 2 weeks. They've got to learn how to shower, all that. It's very difficult. It's more after the surgery that's awkward. In terms of outcomes, most of those people, if you relieve their pain, they're very grateful for that. But it's not a minor thing. When you're fusing joints, you can't replace those joints. I explain to people, when you're talking about the transverse metatarsal arch, the reason there's so many joints there is if you didn't have them there, that your midfoot would crack all the time. Just like if you're in the garden and you build a stone arch, you've got to have joins in the stone. So they're there for a reason. They don't really move. A lot of patients will be concerned when you talk about fusion that they think their ankle's going to be stiff, and you've got to explain to them that's not going to affect that. It's more about pain relief.
Yeah, you picked a good part of the body. I like to joke with people when I see them as a podiatrist, I'm like, yeah, the knee and the hip, and Kelly being a physio, I'm like, the knee and the hip's easy. It's just one joint. When you get down to the foot, that's where the smart people are.
Yeah.
There's so many joints, and the biomechanics is so unique down there.
Absolutely. Yeah. But it's been fun. I mean, foot and ankle as a subspecialty really only started in the 90s and took off, and to be part of something that was new was great. And most of the people, probably a bit older than you two, would know that I was very pro working in teams, multidisciplinary, with the podiatrists and the physios. And a lot of the research, these days I don't do it as much, but spending weekends lecturing out of Cumberland with physios, and if you put on a program, they'll turn up, and the podiatrist. So that's a fun thing to do. But the foot, it's as you said, I always make fun of the knee surgeons and the hip surgeons back at St. Vincent's.
They've got
I can do that with my eyes closed. Yeah.
Do you see outcomes and like on the topic of the knee and the hip? Generally the research, and there's lots of research on knee and hip replacements. When it comes to ankle replacement, do you see the literature similar in supporting people generally having a pretty good response, or it's quite mixed?
Are you asking me now? We're moving off onto a different. You asking me about ankle replacements? Is that what you're asking me?
Yeah. We're moving from we're moving.
So now we're getting into the area of controversy. So okay, so at the moment, the state of play at the moment, there's no. In the literature, if you look at the literature, and this is an area that most people like me have either done replacements and stopped doing them, but essentially it's not a thing that you just ignore, and it's something that you've got to keep up to date. And obviously I'm dealing with people all over the world on a regular basis about what's happening in that area. But at the moment in the literature, there's nothing to support replacement over an arthrodesis or arthrodesis over replacement, okay? But there are differences in terms of, there are a few things that most of the good literature on ankle replacements come out of Canada. The amount of movement you get with an ankle replacement is probably not that much more than with an ankle fusion. There was a study showing that the patients who had the replacement were more likely to be upset with the outcome because they weren't obviously told about how much movement they were going to get. So their preoperative impression was they were going to get all this movement. More importantly, though, is the complications. With a replacement, part of the consent is amputation. If things go bad with a replacement, they go really bad. And if you're going to do them, then you've got to deal with the complications. And if you look at joint replacement in general, hips are the best, then knees and ankles. Whilst there are more being done in Australia than there were, say, a few years ago, but there's still no advantage of one over the other, but you've really got to be very selective too with your patients. If you've got a young patient who's active, you put an ankle replacement in, the hip's not going to last their lifetime if they're, say, 50 years old, let alone an ankle replacement. But then when it goes bad, you're dealing with a massive problem. So, but, to give you a story, when I came back from the States, so a patient came to see me, he'd had an ankle replacement put in the 1970s here in Sydney, and they'd used cement, and the cement, like you get in the hip, it eroded, the cement disease eroded through the medial malleolus, and he had a pathological fracture through his medial malleolus. And I can tell you, to get all of that cement and polyethylene out of there, I virtually used up half of his pelvis in bone grafting. But so they're not new. That's the important thing. And you've just got to be very careful on patient selection. And essentially, there's no evidence still to date that one's better than the other. So
I guess the other thing, as you mentioned previously, that you do need to be very aware of is as you get to that stage of someone's life where they might be more likely to need either a fusion or a replacement, they might have those other comorbidities such as diabetes or smoking or poor
systemic health.
Yeah, systemic health, which is going to then impact healing, particularly distally. So I've got a patient at the moment that I keep seeing these reports coming through for them about a wound that just hasn't healed after a particular foot and ankle surgery, and that needs to continually get debrided because of some of those risk factors. And that's certainly something that you need to be more aware of, I suppose, when we're dealing with the foot and the ankle than potentially the knee or the hip.
Absolutely. Yeah, absolutely. So, you've got to, I think, patients with it, for example, I mean, you're going to be doing, it's ankle arthritis, and the ankle is an amazing joint, because when you think about it, the commonest injury in sport is an ankle sprain, and yet ankle arthritis is actually relatively uncommon compared to knee and hip arthritis. So the articular cartilage in the ankle, even though it's only 1 millimeter thick, and the knee it's 4 millimeters thick, is very resilient to aging and to trauma. So generally with people with ankle arthritis, you would be, say for example, they've got medial wear. Well, an orthotic's going to make a big difference, just trying to offload that. Or if they've got lateral arthritis, you want to put a normal medial longitudinal arch support in, and then shoe wear. So again, all those factors you'd be using, particularly in a younger patient, you're trying to buy them time. If you're going to do something definitively surgically for arthritis, you want to give them as much time, get them as many years out of as possible. And things, it's hard. People get told they've got to lose weight, and they can't walk. It's like a vicious cycle. So again, trying to work around that, it's important. But you're right. But I think from your point of view, anyone with comorbidities and stuff, yeah, and they're being advised fairly major surgery, you want to sort of make sure that you talk to them and try and exhaust all the conservative measures that you can, I think.
Do you see the role for any injectables or pharmacologicals in any of these conditions, like the midfoot or the ankle or anything that you're doing or seeing that is becoming more popular?
I think intermittent use. Some people come and see me and they haven't even started taking, say, for example, anti-inflammatories. So I'll say working with their GPs because some of them can influence blood pressure and stuff. So I'll say go back, right to their GP and say maybe we can start a plan of intermittent anti-inflammatories. Steroid injections, for example, the role of steroid injections can be twofold. It can be therapeutic. In other words, you're looking for a response. Generally, if an injection gives a limited, say, favorable response and doesn't last more than a few weeks, I wouldn't do it again. If it did months, then you might look at it again. But more so, the other role of an injection can be prognostic. So, for example, say you've got someone with subtalar arthritis and ankle arthritis, it's a finger breadth away from the joint, from the ankle joint, the subtalar joint, and you're not sure which one's causing their pain. So I'll get them, say, for example, to have a subtalar joint injection under fluoroscopy. And if they say 80% of their pain goes, then I know the subtalar joint is probably causing most of the problem. So there is, for me, a role with injections. It's more probably on that basis. But generally with injections, I don't think, for example, I found hallux rigidus injections they're not going to help much. And I don't use things like Synvisc and stuff in the ankles. I don't use that sort of stuff.
Yeah. Is that just because it doesn't seem to work? I mean, some of the literature is divided on like PRP even or Synvisc for the knee. And I've seen a couple of people get an okay response, but again, doesn't mean it's great, but the response in the ankle just doesn't seem to be as good. Yeah.
I mean, I think at the moment, more often than not, people will ask you about certain things. And if I don't know anything about it, and I have it, I can go and look it up for them and stuff. But generally, if I don't know, well, then I'm not going to recommend something I'm not aware of. But the role of injections generally, even in the midfoot, say someone comes in with arthritis in the base of their second TMT, which is not uncommon. And there's a role for that. One, see if they get rid of all their pain. And two, you might get lucky and it might give you've just got to explain to them. You don't know what the response is going to be until you do it. I tend to use get it done under fluoroscopy because say they come back to your office and they say the injection didn't work, didn't do anything. Usually they say it didn't work. And you go, hang on a minute. Well, let's go through that. So if it didn't give them any relief and they've had it done under ultrasound, I don't know if it was because the guy was or radiologist was in the wrong spot. Whereas if they do it under fluoroscopy, I can see an X-ray with some dye in it and I know the needle's in the correct spot. So if it doesn't, say they don't get any positive effect, I know that it was because it just didn't work rather than it was in the wrong spot. So there's that issue. So I think injections, there's a role, just depends on what the pathology is.
I have one more question for you, Martin, and probably would have been a better one to ask earlier on, but it just got missed in the list of questions that I wanted to ask you. So we've spoken about the common injuries either being during a sport or those high energy injuries, what actually is happening to the foot for the clinicians listening who are taking a thorough history from someone who might not have footage of the play or the particular incident?
So the mechanism.
Yeah, the mechanism of injury.
So if you look in the sport sort of context, generally their foot is slightly plantar flexed, in a slightly plantar flexed position, and you may get an abduction force applied to it. So in other words, it's a twisting motion. So as you know, all the Lisfranc injury was originally in a horse. Lisfranc was a surgeon in Napoleon's army, and their foot got caught in the stirrup, and so was a twist. So there's that twisting moment with the foot. It's fixed and slightly plantar flexed, and there's a rotary force applied to it. So that's important. With a high energy, it's usually, if the engine of the car's coming through the floor and your foot's got nowhere to go, well, that's pretty obvious how that's more of a direct force.
Mm.
I think it's important, probably for your own listeners. I'll give you an example. And you'll like this. So when I published this paper on the elite athletes in the American Journal of Sports Medicine, this lady came to see me, and she was an equestrian. She competed in equestrian events and stuff. And anyway, she sat down and I said, "You've got a Lisfranc injury, that I'm going to use this tightrope device." And she went, "Oh, fantastic." I said, "What do you mean?" She said, "Well, I've got your article." And I kid you not, this is a month after it was published. She had it on her phone. And she said, "I read your article and I thought, oh, maybe because I'm not a footballer, you won't do that surgery on me." And I said, anyway.
I feel pretty famous for that, the article, like a fan.
So, no. And so, but to give you an idea, I tell people when I was at Royal North Shore as a resident in the orthopedic department, the professor there, Tom Taylor, he paid extra money to get the orthopedic journal sent to him from England and the US, but it was still 6 months after it had been published.
Wow. So
that's in the 80s. So to give you and here's a patient who walks in with she's got the article on her phone a month after it was published. So you can see the value of what you guys are doing and technology and, people's access to information. I think it's very important.
Mm.
So, I'm a big fan of Dr. Google. I know doctors poo-poo it, but, I've got a daughter and a son-in-law work at Google. But I think what it's done is it's empowered people, given them the information. And unfortunately, there's a lot of misinformation out there too. So,
yeah, that's why when coming to do this podcast, we always look around to see what other information is out there. We couldn't find anything at all in video or audio format from someone qualified to speak about Lisfranc injury. So, and we've had lots of people ask us, so it's great. We really appreciate you coming on and offering your time.
Oh, that's fantastic. No, I appreciate it. Even though it's Saturday afternoon, it's like,
yeah,
nothing more you can do.
I know. What else would you rather do on a Saturday afternoon?
Saturday afternoon, that's right.
Now, we wanted to put two last questions on you, and we purposely don't put this in the list of questions, but don't have to answer them, of course. Question number one is, if you could speak to anyone on earth, dead or alive, who would it be? And then secondly, if you could conduct any research, funding, ethics, nothing is limited, what research would you do?
So if I could speak to someone dead or alive.
Yeah, anyone. Like you just chat with them, have dinner, anyone you would like.
Probably Steve Jobs.
Steve Jobs. That's a good one. That's good.
What would you talk to him about?
Lisfranc
injury.
That's very personal.
Yeah.
No, it's funny. I do like reading biographies of various people. And he's slightly on the spectrum, but interesting at the same time. Same with Elon Musk. If you read his, it's fascinating. If you read his biography, there's a photo of his brothers and sisters in the desert. They're somewhere in South Africa as children, and they're all, and I tell this to my kids and stuff, they're all outside this caravan. They're sitting there and they're all reading books, all of them. Which is just what just tells you, so that, but what was the second one about research?
Yeah, so you're able to do any research you like. Funding is not an issue. Recruitment isn't an issue. Ethics isn't an issue as well, which I know is very important. There's no limitation at all, and you get to do anything that you want, study anything that you want. What would it be? You
mean in terms of what I do?
Yeah, like a question that you want to ask from a research perspective where there's no limits.
Yeah, from the ankle, of course.
It doesn't necessarily have to be foot and ankle.
Yeah, it doesn't have to be
well,
foot and ankle.
It doesn't?
Anything in the body, I guess.
Anything.
Oh, yeah, for me, I've got 2 nephews who've got cancer, and so
Yeah, cancer research.
That would
cancer
be
research, especially
absolutely.
for young people. I've got a nephew who's involved with myeloma as the advocate for young people with myeloma. So there's not enough money.
No, not enough money.
Not enough
And
money
it's-
and not enough time, especially when you're young.
especially and researching kids, I think there's a lot of ethical qualms as well. So overcoming that is always a little bit tricky.
Absolutely. So yeah, no.
Right. Thank you
Anyway.
so much for coming on. We really appreciate your time, and thanks for giving up an hour of your Saturday afternoon. We really appreciate it.
No problem. It was lovely to meet you both.
Lovely to meet you too.
Okay,
See you
thank you.
later.
Bye.